Hi, I'm Patrick McCarthy. I'm Executive Director of the Bluhm Cardiovascular Institute here at Northwestern Medicine. I'm very pleased today to be joined by Dr. Rob Passman. Dr. Passman is one of our cardiologists in electrophysiology, and most importantly, he is leading this REACT-AF trial, which is a $37 million grant from the NIH, and it is studying patients in atrial fibrillation. So, Rob, welcome, and as primary investigator of the study, you want to give us an overview of the trial?
Sure. So this trial really grew out of patient care, right? You see patients in clinic who now have very infrequent episodes of AFib because they've lost weight, they've had an ablation, they're on medication. And the question is, do you need to be on anticoagulation for the rest of your life when your episodes are few and far between? So this is a randomized trial of 5,300 patients in about 83 centers across the United States, randomized to either stay on their anticoagulation, the current standard of care, or get fitted with a customized algorithm on an Apple Watch and do what we call pill-in-pocket anticoagulation. Take your anticoagulants only for a fixed period of time, only in response to a prolonged episode of AFib.
So why don't you tell us about the objective of the trial?
Right, so this is what we call a non-inferiority trial. The question is, can we protect patients against stroke equally as if they were on anticoagulation 12 months out of the year, but yet reduce their risk of major bleeds and improve their quality of life, because patients often curtail what they do. They don't go mountain biking, skiing, all those sorts of things because they're afraid of trauma while on their anticoagulants. And can we save money, because the costs of these medications are not trivial, and the cost of major bleeds is a major impact on the healthcare system.
Huge. So for our physicians watching this out there, who's kind of a great candidate for this, and how do they refer patients in to be considered for the trial?
So we're taking patients aged 22 to 85. These individuals have a CHA2DS2-VASc score of 1 to 4 for men and 2 to 4 for women, and they have very infrequent short-lived episodes of AFib for the reasons that we mentioned. They'll have to wear a monitor. This trial is not only downtown, but it's also at Central DuPage Hospital and Lake Forest Hospital, and we have a map of all the sites across the country, so get in touch with me and we'll find a place for you.
Turn ahead 5 years or so. It's a big trial, it's huge, 5,300 patients. So what are the implications of this? What if it's positive? What do you think is going to change in what we do?
Well, first of all, I think this is a huge step forward in sort of personalized care. Right now, we treat all patients with atrial fibrillation with the same dose of the same blood thinners, right, for the same duration, regardless of how much AFib they have. I have a hard time thinking of a lot of diseases where we do that. It doesn't matter how much you have, it doesn't matter whether you're cured from it, you will be on treatment forever.
Right.
So I think this is a major step forward in sort of personalized healthcare, but I think this will be an option for many, many patients moving forward, and patients may opt for stringent rhythm control with things like ablation with the hopes of getting off anticoagulation, which currently is not an option.
Agree, it'd be a huge bonus if we're able to do that. So what should physicians out there know about wearables? What's the future of wearables 10 years from now?
So I think we're going to be seeing more and more wearables for screening the population, for early detection management. I mean, hopefully the holy grails of wearables for blood pressure, glucose, I think those will happen. And my hope is that a study like REACT will have insurance pay for wearables, because it's a lot cheaper to buy someone a band or a watch than it is to pay for all the medications and the procedures that we do.
Absolutely, or treat them if they have a bleed,
right,
or if they have a stroke. So, well, it's really pioneering work, and it really is, talk about state of the art. This is about as state of the art as it gets. So we really appreciate having you here, Rob.
My pleasure.
Okay.
Thank you for having me.
Thanks for all this.